Welcome to The Explainer. Today we're diving into some of the most complex congenital heart defects you are ever going to encounter in pediatric nursing. We're talking about the mixed defects. These are conditions where, basically, the heart's plumbing goes seriously wrong, mixing oxygenated and deoxygenated blood and creating a life-threatening emergency from the moment a baby takes its first breath.
Okay, so here's our game plan. First, we'll nail down the core problem of what a mixed defect even is. Then we'll break down 3 of the big ones you need to know. And we'll wrap it all up by looking at the one critical strategy that acts as a bridge to survival for every single one of them.
All right, first up, let's get to the heart of the matter. What are we actually talking about with this whole category of heart disease? Well, really, it all comes down to the mix.
So think of it like this. Instead of 2 separate, efficient highways, one for the lungs and one for the body, everything gets jumbled together. The blood from both sides blends. And the big takeaway, the blood going out to the body isn't fully saturated with oxygen. That's the central challenge, and it's exactly why we see that classic bluish or cyanotic skin color in these little ones.
Let's jump into our first specific defect, transposition of the great vessels, or TGV. You got to picture this as a major plumbing error in the heart. And trust me, this is a true day one cardiac emergency.
So, everything is backwards. Instead of the right ventricle pumping that blue blood to the lungs to get oxygen, it's pumping it straight out to the body. And the left ventricle? It's taking that nice, red, oxygenated blood and pumping it right back to the lungs where it just came from. You end up with 2 totally separate loops that never cross. It's a closed system, and on its own, it's completely incompatible with life.
So how does this baby even have a chance? Well, there has to be a connection point, some kind of pathway between those 2 loops. This means this infant is completely dependent on another defect, like a hole between the ventricles, a VSD, or between the atria, an ASD, or that little fetal vessel, the patent ductus arteriosus, the PDA. Without one of those to allow for some mixing, no oxygen ever gets to the body.
So when you walk into the room, you are going to see a newborn in some serious distress. They'll have this deep, profound cyanosis, and you'll notice it gets even worse when they cry because they're burning through what little oxygen they have. And that egg on a string sign you might see on a chest x-ray, that's a classic textbook clue for this condition.
So what do? I mean, this is an emergency. This brings us to our number 1 life-saving intervention. That patent ductus arteriosus, that fetal pathway that's supposed to close after birth, is now literally this baby's lifeline. We have to start a continuous IV drip of a medication called prostaglandin E, or PGE, to force that ductus to stay open so that life-saving mixing can happen.
So the immediate game plan is to stabilize with that PGE infusion. Sometimes they'll also do a procedure called the balloon atrial septostomy to create or widen a hole between the atria to help with mixing. But look, these are just temporary fixes. They're bridges. The definitive repair is the arterial switch operation, where surgeons, and this is amazing, literally go in, snip the great vessels, and swap them back to their correct positions.
Okay, next up we have truncus arteriosus. With this one, think of it this way. During development, one big vessel is supposed to divide and become the aorta and the pulmonary artery. Well, with truncus arteriosus, it just never did. So instead of 2 distinct pipes leaving the heart, there's just one, single, massive vessel called the truncus. And it has to do the job of both. It sits right over a large VSD, so it's getting blood from both the right and left ventricles. This means you've got this big mix of purplish blood getting shot out to both the lungs and the body at the same time.
Now, because that single vessel is sending a massive flood of blood to the low-pressure lungs, they're the path of least resistance, you're going to see 2 things at once: cyanosis from the mixed blood and major respiratory distress from all that fluid overload. These babies often present with all the classic signs of congestive heart failure, like wheezing, congestion, and they get tired out really easily during feeds.
Okay, this is where it gets really interesting, and it's a huge nursing point that feels a little counterintuitive. Giving these babies too much extra oxygen can actually make things worse. See, oxygen is a vasodilator. It makes the blood vessels in the lungs relax and open up wide. And while that sounds good, in this case, it just sends even more blood flooding into the already overwhelmed lungs, which worsens the heart failure. The only real fix is a very complex surgery to divide that single truncus and create 2 separate vessels.
All right, our last defect, and it is a big one: hypoplastic left heart syndrome, or HLHS. Now, the problem here isn't a plumbing mix-up. It's that essentially half of the heart is just too small and too weak to do its job.
This is a truly catastrophic failure of development. The entire left side of the heart,
the side that's supposed to be the powerhouse pumping oxygenated blood to the whole body, it's underdeveloped, it's non-functional, it just can't pump blood effectively, which makes this condition 100% fatal without immediate and very complex intervention.
So, if the left side is out of commission, who picks up the slack? It all falls on the right ventricle. It has to become the single workhorse for the entire body, pumping blood to the lungs like it normally does, and somehow supplying blood to the rest of the body. And how in the world does it do that? You guessed it. It is entirely dependent on that patent ductus arteriosus, which lets blood flow from the pulmonary artery over into the aorta.
Now, this is why these babies can seem relatively okay for the first few hours, maybe even a day. But the second that life-saving PDA starts to close on its own, they crash. And they crash hard, going into shock. You'll see this ashen, dusky skin color, rapid breathing, and they just become too tired and weak to feed.
So, what's the first thing we do?
Yep, you know it by now. We start a PGE infusion to keep that PDA open at all costs. But that is just step one of a very long marathon. The long-term plan involves a series of at least 3 incredibly complex, staged surgeries over several years to completely replumb the heart's circulation. For some kids, a heart transplant might be the only viable option.
Okay, so let's just pause for a second. We've looked at 3 really different, really complex heart problems, each with its own unique plumbing issue. But did you notice the one thread, the one strategy that connects all of them? What is that bridge to survival that they all share?
It really just boils down to this. For these infants, the very things we would normally consider defects that need to be closed, like a PDA or a hole in the heart, are actually their only lifelines. They are completely dependent on these extra pathways for that critical mixing of blood that keeps them alive long enough for the surgeons to intervene. This 3-step process is the fundamental playbook. It's the bridge that gets these babies from a life-threatening diagnosis to a long-term surgical solution. First, you stabilize. You keep that ductus open with PGE. Second, you make sure there's enough mixing, either through the PDA or by creating other shunts. And finally, you move on to the complex definitive surgical repairs.
And that's our deep dive. We've unraveled some of the most complex hearts you'll see in pediatrics. But it leaves us with a final really important thought. As our surgical techniques get better and better, we're creating this incredible new generation of survivors. And this means a whole new chapter of lifelong cardiology care is just beginning, presenting brand new challenges for these patients and for the nurses just like you who will care for them across their entire lifespan.